Hello, I'm Jonathan Kruskal, Deputy Editor of RadioGraphics, and today I'm really pleased to be joined by Dr. Aleksandrs Kalnins from Advocate Healthcare Integrated Imaging Consultants in Oak Lawn, Illinois, and the author of a featured paper in the current edition of RadioGraphics. In the Policy, Practice and Quality Initiative section, we do try to identify impactful work that leads to process, compliance, and even performance improvement. And the manuscript published by Dr. Kalnins and his group in this current edition of Radiographic does just that. It also illustrates the very eloquent use of quality tools, of teamwork, and wonderful improvement methodology. This work was completed by Dr. Kalnins while working as a fellow in the Department of Radiology at Stanford University. The study is entitled Decreasing Stroke Code to CT Time in Patients Presenting with Stroke Symptoms, and the paper was solicited as one of the top quality storyboard exhibits at the annual RSNA meeting last year. Dr. Kalnins, welcome to this podcast, and thank you so much for joining us here today. I want to firstly congratulate you and your team on a superbly performed improvement project with measured improvement outcomes. Perhaps we could start by asking you how and why this particular project was selected by your team and how you decided on the goals for the project.
So in order for a hospital to maintain comprehensive stroke center status, it has to demonstrate ongoing quality improvement efforts that aim to improve the processes of, evaluation and treatment of patients in whom a stroke code is called. So our project, specifically decreasing stroke code time to CT, was selected in an effort to continue ED door to CT time improvement in a population of patients in whom this goal can be quite challenging, specifically patients who walk into the ED without a diagnosis of stroke. So we realized that the component of this process in which we could most effectively focus our efforts was in the optimization of the steps that occur once a stroke code is called to the time that a patient receives a CT scan, and that's sort of how we developed the focus of our project.
Great, okay. So perhaps for the listener, you could just give us a brief overview of what the actual project was, and I tend to refer to this as the why, how, who, and what question. So how would you summarize this project briefly?
Yeah, basically, we mapped out the process of stroke codes in the ED step by step through direct observation of the process, mock walkthroughs of the process, and numerous interviews of everybody centrally and peripherally involved with stroke code process in the ED. And then we subsequently optimized the process by eliminating unnecessary steps, reorganizing process steps in order to minimize time, and performing process steps in parallel, which had previously been performed sequentially. So for example, we found that we could avoid having a full EKG of the patient performed on a routine basis in stroke codes, and that it could be simply performed after the CT study as needed. We also found that the full NIHSS stroke scale could be performed after the initial non-contrast CT study is performed. And we basically were then able to use A3 project outlines to track results focused on the 7 components of a quality improvement project, specifically a clear, well-defined problem statement, background of the current problem, a diagram evaluating the current state and talking about that demonstrates the target state, analytic tools using quality improvement methods that a lot of trainees learn in radiology today, as well as an analysis of key drivers and potential interventions, and also a discussion about a sustained plan in order to ensure that the quality improvement process is sustained over the long term.
And that's one of the really impressive parts of the project, is that you have actually been able to sustain, which to the average reader is a very small change, but honestly, to drop a CT scan time down from about 24 to 14 minutes is a dramatic improvement and makes a huge difference to meeting regulatory requirements. To reach your goal, I assume you had to make a few changes and introduce some changes. Can you share any of those with us?
Absolutely. Some of the top changes that we made were basically we let the patient go immediately to the CT scanner without being placed in an ED room when we knew that a stroke code should be called in the patient given their clinical presentation. As I mentioned before, we decided that a full EKG could be performed after the CT scan as clinically necessary. And we also delayed the placement of an IV line, drawing labs, and also completion of the NIHSS assessment until after the non-contrast CT. And basically the second component of the project, the second main intervention, was really to create clearly defined roles and responsibilities for each participant in the stroke code in the new standardized ED stroke code process, similar to what happens during, cardiac codes in the hospital.
Mm.
And some of the challenges, though, in this process were, we had such a great team, a large team composed of a lot of different members of different departments. One of the challenges was, just basically trying to figure out ways for everybody to meet at one place at one time, which made it somewhat challenging. But because everybody was very much inspired towards the same goal of, decreasing time in stroke codes, we were able to do it pretty consistently.
So I'm wondering, obviously the team structure was very important in success of this. And as most people know, the Department of Stanford has developed the so-called RIGHT program, realizing improvement through team empowerment. Perhaps you could let us know how important the actual RIGHT program was in supporting this project, and perhaps just a couple of words about for the people that might not know what the RIGHT program is.
Absolutely. So the structured RIGHT program, as you mentioned, was extremely beneficial. Basically, it consisted of an 18-week structured quality improvement program with 10 two-hour class sessions held every other week on Fridays with all team members in attendance. During each session, there were presentations by quality improvement program leadership as well as project team members. There was group work and activities by which to learn quality improvement methods applied throughout the project, and class discussions. And at home, we actually were able to follow online tutorials that are public access. They're available on YouTube. And the guided program also enabled systematic goals to be set and achieved throughout the process with regular feedback that we got by the radiology performance improvement team in order to make sure that each project progressed appropriately. So it was very beneficial to have a structured program by which to create the process improvement.
So, perhaps a difficult question to answer, but a lot of departments find that one person who's willing to be the temporary quality officer, or call it what you will. How is it that your team or your group were able to actually identify so many champions that, in the old days we like to create the concept of a burning platform. In your case, it seems to be the burning ambition. Why is it that you're also successful in getting so many people to embrace this quite a challenging and long training program?
I think that one of the unique attributes of the quality improvement program in my training program at Stanford was that there was a lot of institutional and organizational support behind the effort that crossed several departments, not only the Department of Radiology. That was one thing. And the second thing is that, comprehensive stroke center status is something that intrinsically involves many departments, and it's something that is a priority for every department involved in the process. And I think for those two reasons, we were able to develop key decision-making, a multidisciplinary team with very influential, experienced individuals and effective individuals from all these different disciplines. And I think that because of the background of institutional support, the understanding of the common importance of the common goal that we were trying to achieve, I think that really facilitated creating and sustaining a multidisciplinary team. And I think that was one of the key components to our success in this project and the ability to sustain our results.
And I think that's an important message for the listener to hear, which is the importance of having the right people, embracing the whole team, providing them with resources. In fact, allowing people the time off to go to an 18-week course is really terrific support from leadership, which is an essential ingredient if you want to get projects to be successful. But perhaps I could ask you one more question. This was a large, wonderful academic department. What advice would you have for other programs who try to tackle basic or more advanced quality projects, for instance, that might be in private practice or non-hospital-based groups? How would a private practice start something like this?
So I guess I have a sort of pragmatic answer to that question. And basically, when thinking about the challenges or the feasibility of establishing a quality improvement program, my advice is that while it may at first seem like undertaking this sort of a endeavor, it may seem like an unnecessary cost and cost center, it's very important to keep in mind that reimbursement, which is linked to programs such as MACRA, will increasingly tie value and quality initiatives to reimbursement as opposed to sheer volume measured in RVUs alone. And the path to creating long-standing and sustainable increases in value and quality is through structured quality improvement programs, such as the example described in our paper.
Well, I think that's very, very helpful. So, Dr. Kalnins, I think to end, I'd like to thank you so much for taking the time to discuss your very impressive paper and approach to reducing code stroke, which really I think is emblematic of reducing throughput in any modality with any particular clinical problem. There are a lot of lessons to be learned from this paper, which can be found online now and will be published in the September issue of RadioGraphics. So thank you very much for your time and congratulations on a very well-performed, high-impact paper. Thank you very much.
Thank you.